And this is just to show you that how complicated this mechanism is. But in short, that is a normal alveolus, and all these processes are active in ARDS. But as a summary, I would say just one thing. It is the damage which causes ARDS. In pulmonary edema, it's the high pressures. So the high pressures, they can be brought back to normal, and a pulmonary edema can return to normal very soon, within hours. But this is due to damage, so it develops slowly and then it doesn't go away until there's some healing. And half of the patients, 40 to 60%, don't survive. The causes, so you can read them, but the common ones are pneumonias and aspiration, and sepsis and severe trauma are indirect injuries. So these are the direct injuries which affect the lung directly, and sepsis and trauma is something which indirectly affects the lungs. So as I am emphasized, there is alveolar damage, there is damage to the capillaries, there is inflammation, pulmonary edema-like appearance, severe hypoxemia, and the lung becomes stiff. The surfactant is also not functioning. And the phases in which it happens, acute phase is the exudative phase, then there's some proliferation, then fibrosis, and then there's a chance of either recovery or death. So those who recover after fibrosis, if the area is not too much, they survive, otherwise they don't. So fibrosis does mean that there's some scar left, but at this stage either there's recovery or there's death. So half the people don't survive this ARDS episode. It is a clinical diagnosis. There is no specific laboratory test which would answer you that yes, there is ARDS. Radiology findings may be consistent, but not diagnostic. So when we see that their appearance looks like pulmonary edema, but it's not getting better, and then if we look at the history and see sepsis or we see trauma, then we start calling it ARDS. Initially it looks like pulmonary edema, we often call it pulmonary edema. But when it doesn't improve, and then we have a look at the history, because it's a clinical diagnosis, we need the history to diagnose ARDS. X-ray alone cannot. So workup is useful in identifying the inciting event or excluding other causes. In neonates, it is infant RDS. So you can have a small eye, and appearance is almost the same in both. The only difference is pulmonary edema develops rapidly, and if treated, resolves or improves rapidly. This develops slowly. After trauma, it takes 8 to 24 hours to develop. So there is an interval in which the lung appears normal. After about 8 to 24 hours, the opacities appear, then they are slow to appear and they just don't resolve. Over the days, you do an X-ray daily or twice a day and you find very little change. Either it deteriorates or it improves. So if it is improves, there is likelihood that the person may survive. If it is getting worse, then the prognosis is not good. Heterogeneous because it can happen through many ways, but usually it's due to immaturity and there is no surfactant. In acute, which happens in adult, it's damage and surfactant also is dysfunctional. But this is usually due to prematurity. So most premature infants, they don't have surfactant and this happens. So it's a heterogeneous lung disease and you get a similar appearance, but the cause here is lack of surfactant and usually premature infants get it. So our last topic is airway obstruction. We have done trauma. We have gone through ARDS, the lung nodules or neoplasms. So the last topic is airway, and airway starts from the nose, the nasopharynx, or from the mouth, oropharynx. So obstruction can happen at any level. So here, can you see obstruction is here? So in a child, it could be adenoids. Do you know adenoids? Yes. Yes. So can you see the nasopharynx, how narrow it has become? Can you see this is a triangle of air? Then between the arrows, can you see a streak of air? Is the mouth open? So the breathing is taking through the mouth. This airway is inadequate to keep the person alive. Can you see how narrow the airway has become? The nasopharynx. So adenoids can cause nasopharyngeal obstruction, and then the alternate route, which is through the mouth, will compensate for it. So the person will survive through mouth breathing only. Then we come down to the epiglottis in the neck. So can you see how narrow it has become here? That is the trachea and that is the oropharynx, and epiglottis is usually at the level of hyoid bone. So can you see this epiglottitis has narrowed the airway? Yes, this is the soft tissue. This is epiglottitis or swollen epiglottis. And the air is coming through this. So ultimately, you will have to do a tracheostomy to directly make the air enter the trachea. If it persists, then this will not be able to support the ventilation, and a tracheostomy will be the way out. So you'll have to put a tube somewhere here. By the way, where does trachea start? At what level? When do we start calling larynx, or when do we start calling pharynx as esophagus and larynx as trachea? It's usually at C6, sixth cervical vertebra level. So if we count, it's approximately at C6 level. Above it, it's either pharynx or it's larynx. Okay, an endotracheal tube was placed, and can you see the narrowing of trachea? So a long placement of endotracheal tube has narrowed the trachea, and now a tracheostomy has been put up below the narrow segment. So that is can you see gradually it's getting narrowed down and almost obliterated, or so a tracheostomy tube is rescuing. So prolonged endotracheal intubation can result in a stricture or stenosis, and tracheostomy done below the stricture will help in causing ventilation. Then, so we saw obstruction at level of nasopharynx by adenoids, at level of the neck by epiglottis, swollen epiglottis. We saw trachea being narrowed in the neck by prolonged endotracheal intubation, and in the lung, the airways, a lobe can collapse, and can you see this is the collapsed lobe? So if there is collapse, you can't just leave it. You have to find out the cause of the collapse. So let's see. So there's a tumor which is obstructing. Can you see this is the bronchus and it's obstructed here? The tumor is the lucent, or this part between the arrows, that is the collapsed lower lobe. So this tumor is obstructing this bronchus, and the lung beyond, or the left lower lobe, has collapsed and become so small. Do you agree that the mediastinum and heart are shifted to the left? So whenever there is atelectasis or collapse, the mediastinum and the structures shift towards that side. So that was airway obstruction at different levels. If there are no questions, then we end the session here.